As you know, primary health care is changing. Statistically, your patients are getting older, they're getting sicker, and before, when they used to have one disease, now they have two or three, which either together or one after another, together or perhaps singly, will lead to their expected death. Similarly, your role is becoming more complex. You're being asked to juggle more balls, if you like, in terms of health care. But luckily, since nursing is female-dominated, you're really genetically programmed to multitask, so you're in the right place. One of the balls that you need to juggle is the management of patients who are at risk of dying in the next 12 months. So what I'm going to say, and this is really selling ice to the Eskimos, you know that you are the linchpin of primary health care. I want to introduce you to some resources that are going to help you to manage end-of-life care proactively, and also to introduce you to a framework of care that allows you to meet the likely needs of people who are in their last year of life, and I'm going to put that in the context of a case study which I'm going to whip through as soon as I can. So why do we think that nurses need to be able to proactively manage people towards the end of their life? Because in spite of all the fancy-nancy things we're doing with medicine and public health these days, death remains a universal health outcome. Your risk of dying is 100%, regardless of what care you receive. So a good death is really a part of good health care, and a good death in the community really does depend on your heart, your compassion, and your extraordinary nursing skills. So the trouble with these expected deaths that we're getting in the older population and the improvements in medical care, in that it's getting much harder to know when to approach end-of-life issues with patients, because the distinction between what's curative and palliative intent is getting really blurred. You know, back in the old days, if you had a bad heart, you had a very good chance of just dropping dead from a cardiac arrhythmia. But now you just get this little critter put in your heart. So if you have a fatal arrhythmia or near fatal arrhythmia, just shocks you back into rhythm and off you go. We know now that breast cancer has really become a chronic disease, so has AIDS. So it gets really difficult to know when to approach these issues, and what we're seeing is with many clinicians, especially the time-pressured ones in the hospital and the GPs, that people are becoming much more hesitant about approaching end-of-life issues. This has got very poor outcomes for patients, because although we know with our clinical skills that somebody may be in the last year of life, they don't know, because they've been told by all their clinicians that we'll manage that. A little bit of dementia, we'll manage that. Bit of heart failure, we'll manage that. Stage 4 lung cancer, let's put you on a trial. So the resource that I really want to tell you about that's going to help you to manage people proactively in the last 12 months of their life is this app that's going to be released on International Nursing Day. I've got special permission to tell you about this. And this app is based on a framework of care that I'm going to tell you about. This app is free to download. I've just been speaking to one of the ladies who helped develop, and she said it's not an app, it's actually a textbook. And perhaps it is, but nonetheless it's free for you. It's on your iPhone. Everything I talk about now will be in this app. So please go ahead, download it. You'll enjoy it. So I said it was based on a framework of care. This is the framework of care. It says it's a framework for palliative care and community-based aged care patients. However, it says aged care because they're the people who funded it. This framework is suitable for anybody who is at risk of dying in the next 12 months. The framework is based on 3 prognostic trajectories, and each of those trajectories is associated with a key clinical process. The key clinical processes for the MOVE one, advanced care planning, second one, case conferencing, and the third one, which is really important, a terminal care management plan for people who you think have been diagnosed with dying and will die in the next week. So how do you start this framework of care? Simply by asking what's become known as the surprise question. Would you be surprised if this patient were to die in the next 6 to 12 months? And I can tell you, all of you out there, you have at least an 85% chance of answering that question correctly for yourselves. So that's a pretty sensitive indicator. However, even if you do get that question or the prognosis wrong, because temporally things can change, you'll notice that each of these columns are joined by dotted lines. So if you get it wrong, you just move someone. The example I always use is Fred. Say he's over in the blue. Fred's 86. He had a bit of an urti and it's really knocked him around. He's got little physiological reserve. He's stopped taking his tablets for the last 5 days. He's put himself to bed. He's a bit peripherally shut down. He's not attending to you. It would be reasonable for you to say, this man is dying. Let's start a syringe driver and keep him comfortable and let the family know. But as we know with frail elderly, once they've had a little bit of a rest from their polypharmacy and once they've had a bit of a rest in bed, suddenly they'll sit up and say, where's the ice cream? So you don't say, sorry Fred, do you see where you are on the framework? You simply stop the syringe driver and move him over to the yellow trajectory. So, this is the SPIC tool. I'm not going to mention it. I'm going to go straight on to our case study in the interest of time. Right. So here's the case study. The case study is about Amber. What a lovely looking young lady she is. A 36-year-old woman, past medical history. She presented with her cough to her GP practice. In 2012, she was diagnosed with triple-negative stage 4 breast cancer with mets to her lung and axial skeleton. You've seen these, the scans light up like a Christmas tree. She was treated aggressively with surgery, chemotherapy, radiotherapy and immunotherapy, and in 2014-15 she underwent 2 clinical trials, plus she's been using alternative treatments. I understand that soursop leaves are very popular these days. At the moment, Amber's a little bit fatigued. She has an occasional low-grade headaches and nausea. Otherwise, she says she's okay. She's pretty confident that the medical specialist will manage her health. She gets on well with them. And she has no documented advanced care plan. It hasn't been suggested. And besides, she's too busy being positive to consider any poor outcomes for her illness. She's a single mum. She's got 2 children, a 10-year-old boy and an 8-year-old girl. Her mother, Beth, moved in to help her after her diagnosis, and she's got a sister, Liv, who used to be a bit of a tearaway experimenting with drugs, but she's sort of come in on the straight and narrow and also moved in to help. Amber herself has been at uni on and off. She's now part-time in the 3rd year of a creative writing course. She's really keen to become an author, and she reckons that she would like to write about her journey and how she battled with cancer and overcame it. So, how do we use the framework? Well, using the surprise question, which trajectory would Amber fit into? Normally I would stop here and have a bit of a discussion with you, but there's no time. So, what we'll do for the purpose of using the framework is say she fits into the first section of the framework, where it would be appropriate to do some advanced care planning with Amber, just to work out we can't practice patient-centred care if we don't know what patients want. I believe it's all of our duty of care to find out what patients want if we think they're going to die in the next 12 months and contribute to their management plan. So, with advanced care planning, it's really the flavour of the month. You've probably heard of it from all sorts of areas. But very simply, all you need for advanced care planning is pick someone who's going to be a substitute decision maker for you, someone who will advocate for you and make decisions if you're in a situation where you can't make those decisions. And then you tell them what you want. That's advanced care planning in about 2 sentences. It gets much more complex, of course. There's legally binding components and less legally ones, less legally binding, but the substitute decision maker is the key to this. And the important thing is, once you know what their plans are, it helps you to inform the management plan for the purpose, for that person. So back to Amber. So, how long have I got? Sorry. Okay. So Beth calls the surgery on a Friday afternoon, Beth's mum. So Amber's had some sort of fit and she doesn't seem herself. You talk to the doctor and very quickly the decision is made to call an ambulance and to get her admitted to find out if this is something reversible and what's going on. Whilst in hospital, she was diagnosed with 4 brain mets. She had 2 lesions suspicious for malignancy, and certainly she wasn't appropriate for resection. She was given a short course of radiotherapy, and then she was dead keen to get home to the kids because she was really missing her. So, which trajectory is she in now? She's now in the second one. So the purpose of this, the key clinical process here is case conferencing. What you want to do is come up with a management plan so that you can proactively organise whatever she will need into the future. So at this point we know that Amber's turned a corner. Amber is on a one-way street. We need to get ready for what's going to happen to Amber so that we don't have to manage things in emotionally charged situations, which often happens, especially in residential aged care facilities or people who are isolated in the community. And this is where nurses are so critical to all of these processes. So a case conference is really a dialogue between all the people who are involved in the care, trying to get everybody on the same page. It's really important to document the outcome of those discussions and to share them with the people you know, so that the people in the house aren't getting mixed messages from the different people who are caring for them. So that's all I'm going to say about case conferencing. Right. So you organised and coordinated a case conference. Amber says she's only going to discuss end of life in a theoretical manner, says she'll live to be 100, but she does agree to appoint her sister and mother as joint EPOAs. It is not surprising that young people won't want to come into these discussions, but as I say, we have a duty of care to let them know the reality. People tend to swing. They will swing between hope and despair. And the idea is we should not collude with false hopes. We need to be a source of truth as well as a source of hope. Hope is a dynamic concept. It can move. You can hope for many things apart from a cure, and you can help people on that journey as they switch from hoping to a cure to hoping for a good death. So Amber agrees to all these various things, and in the end she agrees even to see a social worker to talk about custody of the children in case she gets run over by a bus. And so then the outcome of that case conference should be documented and shared. So now, 6 weeks later, you organise a home visit. Beth says to you she thinks she's having too many narcotics because she's sleeping a lot and sometimes she doesn't appear to pay attention. Now, this may be disease progression. It may be Beth's grief at actually now being faced with losing her daughter, which I can't think of anything worse. and it's unlikely to be the narcotics. I know, I work in a hospital and the first thing they do is stop the pain relief. It is really annoying, and then you just have to start it again. Amber's been in bed for most of the past 3 weeks. She's cachectic and weak, and now she requests information around the dying process because she's anxious about what's going to happen to her and how she'll suffer. She says she wants to die soon and she'd prefer to be dead than put up with the pain in her body. So basically she's now in the third category where what she needs is a terminal care management plan. Now, it's really important to make sure you've got the right paperwork in the house for this. You need to check her meds. You need to have some sort of letter in the house saying that Amber is dying an expected death. So if she dies at home, if the ambulance is called, then they don't call the police and she becomes a coroner's case. That really complicates grief for the families. And you need really to educate now Amber's either her mum or her sister about how to give medication administration, because we know that Amber's going to have a whole cluster of symptoms that need to be managed well, because the aim of this is to get a comfortable looking person in the bed so that she can die comfortably, because that memory is going to remain with that family forever. On Care Search, there's a whole lot of resources about caring safely at home, about teaching lay carers about how to give subcutaneous injections that you can easily access. There's all sorts of diagrams and mock injections so that people can learn how to do it, and you usually find one person in the family will come for, at least one will come forward to do this. This is all colour-coded according to the College of Anaesthetists to increase medication safety. There's all sorts of diaries so that each time one of the members give her a breakthrough medication that they can write down whether or not it was effective or not. So that's great for you. We've got DVDs, we've got books, everything's there, and that it's free to download. What about some other resources that you'd be able to access through that app? There is clinical support. If you can't get onto your GP at night, there is a 24-hour specialist palliative care service available through that number. You are welcome to ring that at any time for advice. First of all, you speak to a very experienced palliative care nurse. If that's not good enough, if you can't get your issue resolved, then you can get put through to the consultant. There's also operating 12 hours a day an advanced care planning phone service, because it doesn't go 24 hours because we figure if you're looking for advanced care planning information in the middle of the night, you're doing something seriously wrong. Now, Decision Assist is a website here that's got all sorts of information available to you. We also have an app for GPs, which is sort of the sister app to your app. So nurses keep saying, are you going to tell the doctors the same thing? Well, yes, we are, and we're crossing over as much as we can. Also free to download. Further, APNA also has palliative care online learning courses, which will be of great value to you if you want to take note of them. And finally, nurses with a unique mix of professional skills, management expertise and emotional intelligence ensure that the whole of primary care team is greater than the sum of its parts, and general practice nurses and practice staff can use a framework of care to improve outcomes for dying patients. And the last one. Thank you very much.